Assalamu alaikum. Thank you very much. My name is Dr. Sadiq Naveed. I'm a child and adolescent psychiatrist at the Institute of Living, Hartford, Connecticut. And my presentation is going to be focused on trends in bullying and emotional and behavioral difficulties among Pakistani school children, a cross-sectional survey of 7 cities of Pakistan. Um, Among my team members, is me, Dr. Ahmed Waqas, Dr. Zaneen Shah, Dr. Waqas Ahmed, Dr. Muhammad Wasim, Dr. Javeria Rashid, and Dr. Tajiba Afzal. So we'll start with the definition of bullying. Bullying is defined as an unwanted, repetitive, aggressive behavior committed by a young individual or a group of young people towards the victim, and a perceived sense of power imbalance in the favor of aggressors. The epidemiology of bullying tells us that worldwide prevalence of bullying is about 33% among ages 13 to 15 years. Bullying has high risk of depression, suicidal ideations, anxiety, sleep disturbance, social isolation, feeling of loneliness, and substance use. Somatic symptoms and academic underachievement is also very common with bullying behaviors among children. Having this in mind, we planned a study in Pakistan with the following objectives: to explore the prevalence of bullying, victimization behaviors among Pakistani school children, to explore the association of mother's employment status with bullying behavior among children, to elucidate the strength of association of different bullying behaviors with strength and difficulties among school children, to identify the mediating effects of pure victimization behavior on the association between externalizing symptomatology and pure perpetration, to identify the mediating effects of pure perpetration behavior on the association between internalizing symptomatology and pure victimization, and to use an unsupervised machine learning technique in order to identify a cluster of emotional and behavioral difficulties associated with patterns of bullying behavior among school children. In our methods, we did this cross-sectional study following the ethical guidelines, such as getting approval from an IRB and getting consent from participants. This study was conducted in 7 public and private schools in 5 districts in Pakistan: Lodra, Rahim Yar Khan, Bahawalpur, Faisalabad, Multan, Thatta, and Nawabshah. Children among ages 10 to 17 years old were enrolled through convenience sampling. Our measures included 4 sections. First section has demographic characteristics such as age of the child, gender, mother's employment status, and background. Second section had 11 items that recorded experience of bullying, victimization as perceived by the participant. Third section was focused on help-seeking behaviors. Fourth section comprised the strength and difficulties questionnaires that has been validated and translated in Urdu in Pakistan. Statistical analysis had series of tests which are beyond my scope of expertise, so I will share the reference for our study that you can go through and read in detail. It included a series of t-tests, Pearson correlation, series of linear regressions, and 2-step clustering methods. Here are some of the salient features of our study. Our sample size included 2,325 participants, and I believe this is the largest sample size study among adolescents in Pakistan. Mean age of the respondent was 14.63 years, so roughly about 14 years. More than half of the respondents were males. Majority reported that their mothers were homemakers. A total of 615, 26% reported being bullied at school, and 415, roughly about 18%, being bullied away from school. So there is a high percentage of bullying in Pakistani school children. Perpetration of bullying was reported by 18.6% participants at school and 16.3% away from school. Being bullied in the past was strongly associated with becoming a perpetrator of bullying in the future. So when clinicians and physicians are working in a patient who has been perpetrator of bullying, they should also explore whether this person has been bullied in the past. Internalizing symptoms, and by internalizing symptoms, we mean depression, anxiety. They were strongly associated with male gender, older age, being a victim of bullying, employment status, and of the respondent's mother. Externalizing symptoms were associated with male gender, old age, being a victim, and perpetrator of bullying, and mother's employment status. Here, I want to point out that being a victim of bullying can lead to both internalizing and externalizing symptom. Not only that, this person can also become a perpetrator of bullying. So we need very targeted intervention in patients who are being bullied and who are also bullying. Our recommendations are that government should launch for a comprehensive multimodal school-based programs to address bullying, and the much of that focus should be on psychoeducation. With that, I will end my remark, and I'm sharing the reference for our study that we did. Thank you very much.